For our next topic, it is the four core steps in essential newborn care. So we should always learn how early breastfeeding can be established after delivery and the impact of hospital practices on the success of breastfeeding. For delivery routines and breastfeeding, infant is most receptive to self-attachment to the breast and breastfeeding after delivery. One factor influencing whether a mother breastfeeds during the immediate postpartum period is standard hospital practices that separate the mother and infant. For standard hospital birthing practices, it is not conducive to maternal infant bonding and attachment or breastfeeding. These practices include suctioning, infant physical exam, vitamin K injection, application of eye ointment, swaddling, and maternal infant separation immediately following birth and during the recovery period. Institutional changes in hospital practices to promote breastfeeding, either as part of independent of the baby-friendly hospital initiative, can be effective at increasing both the initiation and duration of breastfeeding, particularly in developing countries. These may include standalone interventions such as rooming in or a package of interventions such as rooming in, early contact, and health education. The evidence is solid. The four core steps are included in the package of interventions that comprise the essential interpartum in newborn care, or EINC. The first is immediate and thorough drying. Second is the early skin-to-skin contact. Third is a properly timed cord clamping. And fourth is the non-separation of newborn from mother from early breastfeeding. After a baby is born, what should be the first action performed? A. Clamp and cut the cord. B. Dry the baby. C. Suction the baby's mouth and nose. Or D. Do footprinting. The answer is drying the baby. So for the first core step, immediate drying stimulates breathing and prevents hypothermia, which can lead to infection, coagulation defects, acidosis, delayed fetal to newborn circulatory adjustment, hyaline membrane disease, and brain hemorrhage. With just drying, more than 95% of newborns will breathe normally after birth, and only very few babies, or less than 5%, will need resuscitation. While drying the newborn, you should check for tachypnea, retractions, and grunting. Following an organized sequence, we start with the eyes, then the mouth and nose and face, followed by the head, the front and back, the trunk, the arms, and the legs. We wipe the baby gently. There is no need to remove the vernix, which is a barrier against infection. Always remember to remove the wet cloth and replace it with a second dry cloth. So for the first step, we dry the newborn thoroughly for at least 30 seconds and do a quick check of breathing while drying. So we do an organized sequence starting from the head to the toes. If the baby is not breathing, stimulate by drying. Do not ventilate unless the baby is floppy or limp and not breathing. Routine suctioning is not recommended unless the mouth or nose are blocked. And vigorous suctioning can create oral aversion or the baby protects himself by keeping his mouth closed. Next, during the drying and stimulation of the baby, your rapid assessment shows that the baby is crying. What is the next action? A. Suction the baby's mouth and nose. B. Clamp and cut the cord. C. Do skin-to-skin contact. And D. Do early latching on. C. Do skin-to-skin contact. In a 2012 systematic review on skin to skin contact in the immediate post delivery period, it shows that there is improvement in the physiologic transition in the newborn. It increases the success of the first breastfeed. It leads to more effective breastfeeding, and more babies that had been placed skin to skin continue to breastfeed through 1 to 4 months, compared to those with receiving standard care. For skin to skin contact, the general perception it is purely for mother baby bonding. However, it has also other benefits such as breastfeeding success, the lymphoid tissue system stimulation, exposure to maternal skin flora, protection from hypoglycemia, and thermoregulation. So, baby's frontal contact with the mother's body stimulates both the maternal and baby's breast-seeking behaviors. Preterm infants exposed to their mother's milk odor, a natural byproduct of skin-to-skin care, suckle for longer periods of time at each feeding and consume more milk at each feeding when they reach 35 weeks post-conceptional age. Touch is the primary sensory trigger for breast-seeking behavior, along with sight, smell, and hearing, or which we can see that the baby is doing the breast crawl. In semi-reclining positions, primitive neonatal reflexes work in harmony with gravity, less effort required, and less to know and remember. If breathing or crying, position the baby prone on the mother's abdomen or chest, cover the newborn with a dry linen for the back and bonnet for the head. And always remember to maintain the temperature between 25 to 28 degrees Celsius, and the baby should have a temperature of 36.5 to 37.5. When should the cord be clamped after birth? A. When the cord pulsation stops. B. Between 1 and 3 minutes. C. Not less than 1 minute in vigorous preterms or breathing well. Or D. And if the above is appropriate. Any of the above is appropriate. So when we do properly timed cord clamping, it reduces the incidence of anemia by 80% in term newborns and 51% in preterm newborns. It also reduces brain hemorrhage by 41% in preterms. There is no significant impact on incidence of postpartum hemorrhage. For properly timed cord clamping, when preparing for delivery, put on 2 pairs of gloves after thorough hand washing. Remove the first set of gloves, palpate the umbilical cord, and wait 1 to 3 minutes or until the cord pulsations have stopped. So this is how we do the cord clamping. We clamp using a cord using sterile plastic clamp or tie at 2 cms from the umbilical base. Clamp again at 5 centimeters from the base and cutting the cord close to the plastic clamp. Do not milk the cord towards the baby. Observe for the oozing of blood. If blood oozes, place a second tie between the skin and the clamp. Dry cord care is currently recommended. Do not apply any substance onto the cord to prevent infection. And do not use a binder or bikis. The binder in itself, when it gets soiled and unchanged, may harbor germs that will cause infection. It can also rub against the fresh cord and cause irritation. The next step is the non-separation of newborn from mother for early breastfeeding. How long after birth is a newborn typically ready to breastfeed? A. Immediately. B. 5 to 9 minutes. C. 10 to 19 minutes. Or D. 20 to 60 minutes. 20 to 60 minutes. Immediately after birth, the baby will still be fatigued from the process of delivery and will not be ready to feed. When he reaches a quiet state of consciousness in the half to 1 hour following delivery, he will begin to show breastfeeding cues and the signals that he is now ready to breastfeed. This period is crucial for laying the foundation for successful breastfeeding. We should never leave the mother and the baby unattended, and also monitor the mother and baby every 15 minutes in the first 1 to 2 hours. Assess for warmth and breathing. We assess for warmth by checking to see if the feet are cold to touch, if there is no thermometer, and we listen for grunting, retractions, and fast breathing. An early first breastfeed seems to help with increased milk supply in the first days of life. There's earlier passage of meconium, there is greater likelihood of continued breastfeeding, while delay in the first feed can lead to issues of poor milk supply and greater odds of discontinuing breastfeeding. The timing of initiation of breastfeeding is important as there is a higher risk of death among infants with longer delay in the initiation of breastfeeding. So we should leave the newborn between the mother's breasts in continuous skin-to-skin contact, and the baby may want to rest for 20 to 30 minutes and even up to 120 minutes before showing signs of readiness to feed. What is the approximate capacity of a newborn stomach? It's the size of a baby calamansi. For the eye care, weighing, bathing, examinations, injections, including the birth dose of the hepatitis B vaccine, should be done after the first full breastfeed is completed. Inform the mother and record all actions and postpone bathing until at least 6 hours. Bathing the baby in the first 6 hours is protective. True or false? False. The harm of early bathing removes vernix, which is a protective barrier to E. coli and group B strep, which can cause infection. It also hinders crawling reflex and can lead to hypothermia. For the 9 instinctive stages after birth, first is the birth cry when the lungs expand. Relaxation, there is relaxed hands and no mouthing. Awakening, there is already small head and shoulder movements. For the active, there is more head and shoulder movements. Crawling may occur between any two stages. Resting is when there is movement to the breast. Familiarization by licking the nipple and touching the breast. Suckling by latching and suckles. And sleeping while when the baby falls into a restful sleep. For breastfeeding cues and feeding reflexes, the range of semi-reclined maternal postures interacting with neonatal positions, releasing maternal instinctual behaviors, and primitive neonatal reflexes stimulating breastfeeding. More reflexes act as breastfeeding stimulants when mothers lay back, or when the mother is relaxed. For breastfeeding cues or feeding reflexes, there is head lifting and bobbing, increased alertness and movements of arms and legs, tossing and turning or wiggling. There's mouthing, licking or tonguing, rooting reflex, hand to mouth, changes in facial expression, and squeaking noises or light fussing. We should always remember that crying is a late sign of hunger. So for early breastfeeding initiation, we should let the baby feed for as long as he or she wants. The healthcare worker should not touch the newborn unless there is a medical indication. Do not give sugar water or formula. Do not give breast milk substitutes or bottles and pacifiers, and never throw away colostrum. Giving pre-lactales delays the mother's breast milk letdown. The ease of feeding from the bottle decreases the newborn's urge to suckle. A vicious cycle is created that causes caregivers to continue pre-lactal feeding, and there are more episodes of diarrhea in the first 3 months compared to those who were not fed pre-lactales. For artificial breast milk substitute, it exposes the newborn to different types of infectious agents, as well as challenges an already weak premature or immature gastrointestinal system. For the newborn procedures, the eye care, weighing, examinations, injections, including the hepatitis B vaccine, should be done after the first full breastfeed is completed. Weighing of the infant can be deferred unless the newborn is of significantly low birth weight or less than 1,800 grams to 2,000 grams, less than 34 weeks gestational age, and has signs and symptoms of illness requiring a transfer to NICU. Waiting for the first breastfeed did not lead to adverse effects from a microbiological perspective. Injections can be delivered while the newborn is skin to skin and are breastfeeding. These have been demonstrated to diminish pain responses in the newborn. And newborns who require heel prick for asymptomatic hypoglycemia may also have these done while they remain skin to skin. So we should never overstimulate the baby by doing multiple assessments, suctioning, weighing, and measuring, doing glucose checks, eye treatment, and injection, which could cause the baby to shut down. It could also lead to a sleepy baby that's difficult, if not impossible, to nurse. Routinely separating babies from their mothers for evaluation and bathing during the minutes and hours after birth disrupts the baby's ability to find the breast and self-attach. For the harm of early bathing, it removes the vernix, which is a protective barrier to E. coli and herpes strep. It hinders the crawling reflex and can lead to hypothermia. Factors affecting breastfeeding. There is strong effect on the success of the first breastfeed as did pethidine given during labor. Two crucial determinants for a successful start is uninterrupted contact with the mother until after the first feed and no sedation of the infant by analgesics given to the mother during labor. Side effect of such narcotic analgesics is CNS depression of both the mother and the baby. Special consideration is given for premature or low birth weight infants, especially when it comes to hyperthermia, which could present with tachypnea and retractions in a cold environment. So we should maintain the temperature of the room between 25 to 28%, maintain skin-to-skin contact, and monitor the baby closely. And the baby's temperature should be between 36.5 to 37.5%. For post-resuscitation of primary apnea, this will be discussed further. So we have this graph for the EINC mother and baby diet monitoring sheet. This is the WHO Essential Newborn Care Algorithm. So the first step is the one we did, the essential newborn care from the arrival of the mother at the health facility. And then for the delivery, we should call out the time of birth and sex of the baby. Deliver the baby onto the dry cloth draped over the mother's abdomen or arms. Start drying the baby within 5 seconds after birth. We wipe the eyes, face, head, trunk, back, arms, and legs thoroughly and check the breathing while drying. After drying and seeing that the baby is breathing well, remove the wet cloth to start skin-to-skin contact and do the second core step. Replace the wet cloth with a dry one to cover the baby and a bonnet on the head. As the baby is on the mother's chest, resume care for the mother and give oxytocin, then back to the newborn to clamp and cut the cord after at least 1 minute, which is the third core step. And the number 4 is the non-separation of the newborn from the mother. Breastfeeding is encouraged once with feeding cues seen, and other routine newborn care will be done after the first full breastfeeding. You should always monitor the baby every 15 minutes and postpone bathing until after 24 hours of age. The evidence is solid. The 4 core steps in immediate newborn care will save lives. Just before we end this lecture, know that we have learned is part of a bigger program, the Early Essential Newborn Care. As the goal is to reduce newborn deaths, this has strategies for both the well and at-risk newborns. The latter includes small babies and the sick ones. Resuscitation is included and will be discussed further in another lecture. In summary, maternal and neonatal mortality in the Philippines is still unacceptably high. Prevention of postpartum hemorrhage through interventions like the use of AFTSL will address the number one cause of maternal mortality, and the evidence-based practices in the EINC protocol are life-saving for the mother and the baby. Appropriate hospital routines greatly affect the establishment of effective breastfeeding. The four core steps in immediate newborn care lead to early initiation of breastfeeding, and healthcare workers' knowledge and appropriate management of newborns in special cases is essential. Newborn mortality is still high. Existing perinatal practices predispose newborn to an increased risk of dying immediately after birth. The four core steps in immediate newborn care save lives. Every newborn has needs: to breathe normally, to be warm, and to be protected and fed. Let us put everything into practice.